Okay, so thank you so much for joining me today, Dr. Ighodaro. I know you're extremely busy up there at Mayo Rochester, but I wanted to take the opportunity to have you talk to us today about um, racism in the setting of clinical trials, particularly in the US, anti-Black racism in the setting of clinical trials, although we are seeing, of course, and we know that this is a worldwide issue and that many groups are affected in similar ways in different places. So could you?
Thanks for having me.
Wonderful. I'm happy to have you. So talk to me a little bit about how you see racism and how we as clinical trialists need to think about racism.
So as a Black female, when I think of racism, there's many different degrees of racism. And I think when we hear racism in society, we think of the overt racism where you have individuals who are non-Black, who will say racial slurs, who will, have the Confederate flag waving, who will, protest outside people, people of colors, houses and telling them that they don't want them to be there. So these overt outward actions, I think, is what the public thinks of when they think about racism. And for me personally, racism comes in all different kinds of acts, not just the ones that are very overt or in your face, but also those that are microaggressions, there's structural racism, systemic racism, unintentional racism. So I think there are many kinds of racism that fall under this umbrella of racism, not just the overt, in your face, anti-racist acts. That would be how I experience it in the US.
Okay, thank you so much. Can you talk a little bit about how all of those different forms of racism affect the practice of clinical trials?
I think as much as we as scientists and intellects would like to say, we're educated. So because we're educated, we're immune to the ideas and the isms that are part of our society. And unfortunately, that I believe personally that's not the case. We are a product of our education, of our society, and some of those ideas and concepts do feed into the way we design clinical trials, the way we study clinical data, and the way we analyze it. And I don't think anyone overtly wants to perpetuate racism in our work. And I think all of us have great intentions, but I think there are unintended consequences if we do not be critical of how we design our scientific methods, because it is a product of our educational system. And if we don't be critical of our methods, we will continue to further create these health disparities in oppressed populations.
Can you give me a couple of examples of unintentional racist practices that you're aware of in clinical trials, for example?
Yeah, I think the biggest one that I've seen in my work, so Dr. Abner was one of my thesis mentors at the University of Kentucky, and I was looking at one of the data sets in the Alzheimer's Disease Center, and I realized looking at the demographics of those data sets, it's probably 95% self-identified white Americans, and then the other 5% is consistent of people from other different backgrounds. And I would look at this data set, but then I would look at papers that come out of it, and I would see that there would be scientists who would publish data talking about the prevalence of dementia in the African American community, referring to this data set that is extremely overwhelmingly white. And it really bothered me that we would take a data set that wasn't representative of the population and that had maybe very extremely few numbers of African Americans, yet the collective we would publish this data making claims that based on this data set, this is the incidence of AD in African Americans, when if you would look at the numbers, one could argue that that is not representative at all, and that does a disservice to the African American community because we're perpetuating statistics that may not in reality be true, given the inherent lack of representation in these data sets that we use to study dementia.
Yeah, so diversity and inclusion and research participation are incredibly important, right? And iStart has a professional interest area that's totally dedicated to diversity and inclusion. And we have seen over the last probably 20 years, big improvements, not acceptable, not where we want to be, but big improvements in representation of research participants, both in observational studies and clinical trials.
Mhm.
Let's say that we were able to somehow perfectly recruit and get representative participants. Would that solve the problem for clinical trials, or do we need to think more carefully about this?
No, I think it's a step in the right direction, but I think just because we have a data set that's representative of the community that they are based in doesn't mean that the analysis that comes out of those data sets is still not problematic. And I think it starts from really understanding, we can go to the beginning. What is this variable that we call race, and what does it really mean? Because I think in reading the literature, at least in neuroscience, I think we are quick to correlate racial differences to genetics when there are many other variables that are confounded in this variable that we call race, socioeconomic status, education, access to healthcare. And I think what we have not yet studied, but I think there's also other things such as discrimination, racism, and stressors of being Black in America that not directly, but that could possibly correlate with health outcomes. Because we all know that stress, is something that causes increased comorbidities. And does this stress coming from being Black in America lead to the health disparities that we see in stroke, hypertension, diabetes, Alzheimer's, and vascular dementia?
Absolutely.
So the answer to your question is no. There still needs to be a lot more that needs to be done. But I think the having representation is a step in the right direction.
Yeah, I agree. It's absolutely essential. What about diversity and inclusion among the people actually conducting the trials? What do we need to think about there?
Definitely. I think that's extremely important in that we have diversity and inclusion of different minds, and we talk about this in the paper that Dr. Abner and I published together in the Journal of Alzheimer's Disease. Challenges and considerations for studying African Americans' dementia. I think the diversity and inclusion goes in our experiences and our disciplines. Because if you take a sociologist, epidemiologist, historians, neuroscientists, and you put them in the same room, each of those team members has different expertise that can help in better understanding the race variable in society, so that we can design studies that are more comprehensive and are not, in my opinion, damaging to the population that we intend to study. So I think diversity of thought, diversity of expertise, diversity of experience are all steps in the right direction to create a better scientific team.
Absolutely. What are some things that we could do right now? I've seen some conversations, for example, on the language that we use when we talk about participants and the results of the analysis, right? What's wrong, or what would be a better way of phrasing it than to say that Black Americans are at much higher risk, potentially, of dementia than white Americans? What's wrong with that? How could I say that better?
Right, and I think, I found the conversation that was online from the physician scientist who brought up that really interesting topic. So it's Dr. Timoria Lewis, who's a physician scientist, and what she said is she really talked about changing our language when we're publishing data on health disparities, away from pathologicalizing the Black population to more pathologicalizing the systems that are set in place to create these health disparities. So she gave an example of in Black mothers and OB-GYN data. So she said, instead of saying the cumulative effects of instead of saying Black women have higher rates of preterm birth and prenatal mortality, because that then puts the onus on the Black woman, because then it makes it seem like it's the Black woman that is inherently predisposed to having worse outcomes than white women. She said, if you change the language and put the onus on the system that we all live in, then it frames the interpretation differently. So instead of saying what we typically say. She says, you know, you can say it in this manner. You could say the cumulative effects of interpersonal, institutional, and structural racism place Black mothers at risk for preterm labor and prenatal death. Because then it changes the framework, and I think it allows for more conversation. Instead of it being innate to Black people, it's in their genes. There's nothing we can do about it.
Exactly right. Exactly right. What about when we talk about recruitment, things like calling populations hard to reach? Is that damaging in any way?
I do, because again, it's changing the language. Is it that those populations are hard to reach, or is it that our methods are designed in a way that makes it difficult for certain populations to be able to reach us? You know, people, middle class people who have access to transportation, cars, money, them driving to our institutions, it's not a barrier for them. But people who live out in different communities, who maybe don't live close to an academic center, you know, don't have access. You know, they're trying to, you know, feed themselves, let alone take a bus, you know, 2 or 3 buses to come to a research facility, you know, to participate in clinical trials. And then in that mindset, it's like, well, why would they want to do it given the historical mistreatment of Blacks with clinical trials in medicine? So I think if we, again, change the terminology in that populations are not hard to reach, we're making it difficult for them to reach us, and it puts the onus on us to create different methods in reaching them.
Right. So one of the themes that we keep coming back to is the importance of seeing the system that's around us, right? And not hyper focusing on the trial itself and the results of the trial, for example, but remembering that our trial participants exist in a system outside the trial, that we, the researchers, exist in a system outside the trial, and that the system definitely disadvantages certain groups and advantages other groups. And I'm obviously so proud and impressed with everything that you've done. But it has to be said that you were the first Black woman to graduate with an MD PhD from the University of Kentucky College of Medicine. And I know, as wonderful and brilliant as you are, that there were Black women before you who were also wonderful and brilliant, and yet they didn't get there. And so what do we need to think about in terms of pipelines?
Mm-hmm. I think that's a phenomenal question. And I think it's a question that's starting to, you know, I think a lot of people are starting to think about these questions in light of everything going on in cultural events. And in my experience at the University of Kentucky, and this is probably similar experiences across the nation, there were movements happening a couple of years ago across campuses because there were a handful of Black professional and graduate students. So these are people who were not in undergrad, but were in professional schools and graduate schools. There was like a mass exodus of people leaving. And the issues, we were trying to figure out why is that the case? And then people who were talking to me, they would tell me they just didn't feel welcome in academia. They felt oppressed. They felt many times they were isolated. They were the only one. And when they were trying to talk about some of their ideas that may be unconventional, they would get pushback from it. So if you're in a highly educated academic environment, you're the only one, you feel that you are isolated because of your skin color, because of your thoughts, because of your beliefs. And then you have people who are racist overtly and, you know, inadvertently racist to you, that it makes you not want to stay in that kind of environment. So I think those are the reasons why, you know, in 2020 or in 2018 when I graduated, I was the first, even though, you know, slavery has been over for a long time. There are still things in our society that prevent Black individuals from being successful in academic settings. And I think a lot of it is the culture. And once we start changing the culture and being more inviting to people of color, to people of different walks of life, then we'll start to make a difference in the people in academia. And then when these people get up to, you know, professors, tenures, clinical trialists, then we'll even have a better outcome in the work that comes out of academia.
Thank you. And so what I'm hearing you say there is that it's not enough simply to recruit more Black students, for instance, or to hire more Black faculty into the systems that are already there, because the system itself is not welcoming and supportive. And so again, we have to keep our eyes on the system.
Exactly.
All right. I think we are almost out of time. Can you talk about some of your work in activism and some of the work that you're doing on social media now?
Oh, thank you. So the work I did in activism at UK was really focused on trying to make the environment more welcoming for African American students. And some of the positive things that came out of it was restructuring of resources to support Black students across campus. They implemented a racial bias incident report so that when things did happen to students of color, or any student, no matter what their social identity was, they could report it in a way that the university could keep track and hopefully make changes to decrease the amount of time that those incidences were happening. And one recent result that came out of our activism on campus was there was a mural in one of the big town hall classrooms that was very oppressive for students of color. For many years, we were trying to get the university to take it down, and recently they decided to take it down. So by speaking up and letting academia know about these concerns that are preventing the retention and recruitment of Black people on campus, hopefully now that some of these have been implemented, it'll be in the right direction to help recruit and retain more students of color. And then on your second question about my social media, so one thing that I've started doing on social media is making myself present on social media, and I've been well perceived. I think the most touching messages I've gotten were from students who said, who are Black females, who said, I've never interacted with a Black scientist or a neurologist. I didn't know if I could myself be and be in that career, but now that I see you and you're doing it, it makes me more hopeful that I can also do it as well. And it just was very powerful for me to hear that I can outreach to people across the country, across the world, about the work that I'm interested in doing. And I also do a lot of education because I believe, and I hope that as scientists, we don't keep our information in the ivory tower, that the reason why we are here and we're doing the work that we're doing is for the public. And I hope that we can do a better job of disseminating that work to the public using the social media engine. So I do a lot of educational videos as well in neuroscience and in neurology. So I hope that you guys can spread my channel to your colleagues, and also work toward making science and research more less oppressive and more I can't think of the right word I'm looking for, but my hope is that us as a scientific community can do better in creating and designing studies that help improve the health of people of color.
Absolutely. And I just want to follow up on two things. One is that the mural that you spoke of is something that Black students and Black faculty have been advocating to have removed for quite a number of years. And so one of the lessons is that change is possible, but it may require a lot of persistence and a lot of time. And the other thing that I draw from what you said is that even though it's not enough to increase representation, it's critical and it matters.
Yes, I completely agree.
Okay. Do you have any final thoughts for me, Essie?
Let me take a look. I guess,
okay.
I mean, I'm glad that you pointed out the need for, these kind of talks and these kind of, possible solutions in what we're doing as scientists. I think it starts, with us. I think it starts with the data, because the data directly impacts how we practice medicine. So we can really take a critical analysis of what we're doing. And I know all of us are well-meaning, well-intentioned, and be open to constructive criticism for the betterment of society, then I think that's phenomenal and powerful. So thank you for having me. Thank you for taking the time to, ask for my advice. And thanks to the audience who will be listening.
Absolutely. Thank you again for joining us, Dr. Eseosa Ighodaro.
Thank you, Dr. Abner.
All right. Bye-bye.